topic we are going to discuss is about antidepressants. Starting with depression, worldwide depression has become one of the most commonest mental illness. It is characterized by feeling of intense sadness and despair, slowing of thought processes, impaired concentration, constant worry and agitation, and self-deprecation. Coming over to antidepressants, they are simply nothing but drugs which are used in the treatment of depression. They function by elevating the levels of certain neurotransmitters in our body like dopamine, serotonin, and norepinephrine. This has also been explained by a thesis named as monoamine hypothesis, which expresses the three important monoamines in our body, which is dopamine, norepinephrine, and serotonin, and explains that the depletion or decrease in any one of these amines or all the three amines results in depression in a person. Here's a video showcasing the basic mechanism of action of depression. This is our presynaptic serotonergic neuron, which is responsible for producing serotonin in our body. On the other side, we have our presynaptic noradrenergic neuron, which produces norepinephrine, or also called as noradrenaline, in our body. To receive signals from these neurons, we have receptors below them. On the right side, we have our postsynaptic noradrenergic receptors represented as beta and alpha 1. On the left side, we have the serotonergic receptors represented as 5-HT, which means serotonin. They have further subtypes like 5-HT1A and 5-HT1C, but for better understanding, we have represented it as 5-HT. Moving on to how serotonin and other neurotransmitters are produced in our body, the serotonergic neuron, to tryptophan amino acid, produces serotonin and stores it in a vesicle until it is released. On the other hand, the noradrenergic neuron, to tyrosine amino acid, produces norepinephrine and stores it in a vesicle until it is released. Once these neurotransmitters are released from the vesicle, they cross the synapse and reach the receptors. Upon reaching the receptors, they stimulate the receptors and starts a process called as reabsorption. In the serotonergic neuron, this process occurs by the help of serotonin transporting channel, where these channels reabsorb the serotonin into the neuron again. On the other hand, in the noradrenergic neuron, a channel called as norepinephrine transporter is responsible for transporting or reabsorbing these neurotransmitters into the neuron again. Upon reabsorption, these neurotransmitters get packed in the vesicle again. Here comes the role of the main element, which is monoamine oxidase enzymes in our body. They are present in two types, type A and type B. Here, they function to break down the neurotransmitters inside the vesicle and inactivate them, and thus decreasing the levels of these neurotransmitters in our body and ultimately causing depression in a person. Let's move on to the classification of antidepressants. They are categorized into four types: norepinephrine or noradrenaline reuptake inhibitors, also called as SNRIs or TCAs, selective serotonin reuptake inhibitors SSRIs, monoamine oxidase inhibitors MAOIs, and at the last, atypical antidepressants. Norepinephrine or noradrenaline reuptake inhibitors function to inhibit the reabsorption of norepinephrine back into the neuron, while selective serotonin reuptake inhibitors function to inhibit the reabsorption of serotonin back into the neuron. Monoamine oxidase inhibitors inhibit the monoamine oxidase enzyme in our body and thus prevent the breaking down of neurotransmitters in the body. At the last, atypical antidepressants. They are different from the previously mentioned three classes of drugs, and they are opted only when all the three classes of drugs have been administered to a patient and they do not show any significant improvement in the treatment. Starting with the first classification of drugs, norepinephrine or noradrenaline reuptake inhibitors. They are also called as tricyclic antidepressants or cyclic antidepressants because of their molecular structure. Common examples include clomipramine, desipramine, dibenzepine, and lofipramine, and they are usually used in conditions like depression, panic disorder, social phobia, narcolepsy, which is a chronic sleep disorder, attention deficit disorder, and childhood aneurysms. Moving on to toxicokinetics, all cyclic antidepressants are rapidly absorbed from the gastrointestinal tract and they are metabolized in the liver by first pass metabolism. Their half-lives usually ranges from 4 hours to 93 hours and they exhibit significant toxicokinetics when consumed in large quantities. In mode of action, they are structurally similar to the phenothiazines and exhibit anticholinergic, adrenergic, and alpha-blocking properties. They function by inhibiting the voltage-gated sodium channels in the myocardium, and when consumed in overdose, they cause complicated interactions in the brain and may even result in convulsions. Adverse drug reactions usually include postural hypotension, cardiac arrhythmias, vertigo, tremor, weight gain, tachycardia, hypertension, mydriasis, visual blurring, and constipation. Overdosing of cyclic antidepressants usually results in seizures-like symptoms. Other symptoms include tachycardia, hypotension, hallucination, confusion, and sometimes may also cause coma. Coma is usually short-lived and the patient usually wakes within 24 hours. Neuroleptic malignant syndrome, which is a rare and life-threatening condition caused by psychotic drugs, has also reported in some cases of overdosing. Moving on to fatal dose, cyclic antidepressants can be fatal above the age of 30 years. Also, serum drug levels greater than 800 mg per ml. When a patient consumes cyclic antidepressants 10 times greater than the actual therapeutic daily dose of the drug, it can potentially become fatal. Under diagnosis, serum electrolytes, renal and hepatic functions in patients should be monitored. Also, serum tricyclic levels are useful in confirming a history of ingestion of drug. ECG changes and elevation of creatinine kinase and also lactic acid dehydrogenase levels should be monitored. And at the last, chest X-ray can be obtained to detect pulmonary edema. Coming to treatment, supportive measures like maintaining the airway, intubating if required, administration of oxygen when necessary, and monitoring arterial blood gases are done. To reduce the drug absorption in severe cases, stomach wash can be done within the first 6 hours of ingestion of drug. Also, activated charcoal can be given. Dose is 1 gram per kg. To treat convulsions, diazepam 0.1 mg per kg through IV is given, and phenytoin 15 mg per kg IV infusion is given. To treat arrhythmias, serum alkalization by using intravenous bolus of sodium bicarbonate can be administered. Coming to second generation of drugs, selective serotonin reuptake inhibitors, these drugs are more safer and better tolerated than the first generation of drugs, which include cyclic antidepressants and monoamine oxidase inhibitors. Important examples include citalopram, duloxetine, fluoxetine, fluoxamine, oxaflozine, paroxetine, sertraline, and venlafaxine. They are usually used in conditions like depression, panic disorder, sleep disorders, and migraine. Coming to toxicokinetics, all selective serotonin reuptake inhibitors except paroxetine and sertraline are rapidly absorbed on oral administration. Since paroxetine and sertraline are absorbed slowly, under overdosing cases too, they exhibit signs and symptoms very slowly. The primary route of elimination of all these drugs are renal. Under mode of action, the selective serotonin reuptake inhibitors function by inhibiting the reuptake or reabsorption of serotonin into the serotonergic neuron and thus balancing the levels of serotonin in the body. In addition, they also alter the sensitivity of serotonin subtypes 5-HT1A and 5-HT1C receptors. Moving on to clinical features, SSRI overdosing usually results in symptoms like abdominal pain, nausea, vomiting, diarrhea, vertigo, lethargy, insomnia, diplopia, CNS depression, tremors, and rarely convulsions. Discontinuation of a SSRI classification of drug called sertraline might lead to symptoms like fatigue, nausea, abdominal cramps, shortness of breath, memory impairment, dizziness, insomnia, chills, and eye discomfort. Under treatment, it usually involves supportive measures like stomach wash, but should be done only under severe conditions. The syrup of ipecac, the most commonly known emetic, should not be used in this case as it contraindicates with SSRI type of drugs. The serum levels are not clinically useful in managing overdosing. Also, monitor for evidence of serotonin in the body. In conditions like QRS prolongation or arrhythmia, sodium bicarbonate can be administered. Moving to monoamine oxidase inhibitors, they have been largely replaced by the cyclic antidepressants but still are used in certain types of anxiety and phobias and some types of treatment-resistant depression. Important examples include isocarboxacid, iproniacid, lazabimide, moclobemide, phenelzine, pimozide, and selagiline. They are usually used in conditions like depression, agoraphobia, anxiety disorders, panic disorders, phobic disorders, and also Parkinson's disease. Coming to mode of action, they primarily inhibit the monoamine oxidase enzyme and prevent them from breaking down the neurotransmitters. They are flavin-containing enzyme located in the mitochondrial membrane of liver. Monoamine oxidase inhibitors can selectively inhibit either type A or type B enzyme. For example, meclobemide and chlorgyline are selective monoamine oxidase A type of inhibitors, while lazabimide, pargyline, and selagiline can selectively inhibit monoamine oxidase B enzymes. Signs and symptoms include anxiety, flushing, headache, tachycardia or bradycardia, hypertension or hypotension, agitation, delirium, which is a confused state, hallucination, tremors, coagulopathy and hemolysis, and finally even death. Moving to treatment, overdosing conditions of monoamine oxidase inhibitors show signs and symptoms very gradually and also slowly. So, if a history of overdosing is present in a patient, even if there is no symptoms, the patient should be admitted to the ICU within 4 to 6 hours of ingestion of the drug, and his vitals should be stabilized within 24 hours. In addition, airway oxygen and assisted ventilation should be provided if required. The electrolytes should be monitored closely, particularly in conditions like hyperkalemia. Liver and renal function tests can be taken, and also creatine phosphokinase level should be monitored. In conditions like hypertension, IV sodium nitroprusside or phentolamine methyl-dopa can be suggested, and in cases of hypotension or shock, IV fluids, vasopressors like noradrenaline and dopamine can be provided. Under ventricular tachyarrhythmias, lignocaine, phenytoin, or procainamide can be administered to the patient. The last class of antidepressants, atypical antidepressants, consist of two major drugs, bupropion and mirtazapine. Bupropion is a unicyclic antidepressant which acts by inhibiting the neuronal reuptake of neurotransmitters like dopamine, noradrenaline, and serotonin. It also has moderate anticholinergic activity. It is usually used in conditions like attention deficit disorder, reduction of cocaine use, diminishing the craving for chocolates, and also in smoking cessation. Overdosing of this drug can result in symptoms like vertigo, vomiting, meiosis, tachycardia, hypokalemia, and also convulsions. Under treatment, seizures and mental status changes should be monitored, and also serum creatinine and creatine kinase levels should be monitored to detect rhabdomyolysis, which is a deterioration of muscle in body. Hypokalemia must be corrected, and there are no life-threatening toxicity in this drug. Coming to mirtazapine, it is a tetracyclic antidepressant belonging to the piperazine group of compounds. Adverse drug reactions are usually very few, and hence this is a safer drug to use. Some symptoms include tachycardia, hypertension, hypotension, CNS depression, confusion, arthralgia, myalgia, and dry mouth. Overdosing is also very limited in this case. Some features include CNS depression, tachycardia, meiosis can also happen in some cases. Treatment includes complete blood count monitoring, urine analysis, and liver and kidney function tests in patients with significant exposures. It is also advisable to monitor the vital signs, and continuous cardiac monitoring should also be done.